Assalamu alaikum. Our topic today is going to be non-Hodgkin lymphoma. Before we go into this topic, let us review the structure of a lymph node briefly. As you all know, lymph nodes are distributed all over the body as part of the lymphatic system. The lymph node has a capsule right here. Through the capsule enter afferent lymphatic vessels carrying lymphatic fluid. The lymphatic fluid contains T and B cells. The T and B cells go through very complicated process within the lymph nodes, especially in the lymphatic follicle and the germinal center, which is within the lymphatic follicle. Then the mature or processed lymphocytes leave the lymph node through the afferent lymphatic vessel. Lymphoma originates from different parts of the lymph nodes. For example, follicular lymphoma originates from within the lymphatic follicle, and diffuse large B-cell lymphoma originates from germinal center. Non-Hodgkin lymphoma are malignancies that originate from either B-cell progenitors, T-cell progenitors, mature B cells, mature T cells, or natural killer cells. Presentation. Because lymphoma is a heterogeneous malignancy with tens of types and subtypes, we do not expect lymphoma to have a common presentation other than lymphadenopathy. Even lymphadenopathy varies. For example, low-grade lymphoma may present with slow-growing, painless, enlarged lymph nodes. For example, a man may find an enlarged lymph node while shaving. On the other hand, for example, Burkitt's lymphoma may present with rapidly enlarging, painful lymph node. Lymphomas share what we call B symptoms. Not all of lymphomas, but most of them share B symptoms: fever, night sweats, and weight loss. Sometimes patients present with fatigue or totally asymptomatic, no B symptoms. But lymphoma varies according to histologic subtypes. For example, Burkitt's lymphoma has acute presentation, days or weeks. Diffuse large B-cell lymphoma has subacute presentation, and low-grade follicular lymphoma, especially grade 1, has a chronic presentation over years, and also varies according to the sites. For example, lymphoma of the stomach presents with GI symptoms, skin rash. Lymphoma of CNS present like a stroke or with seizure. Also, lymphomas may present with different emergency situations. For example, high-grade lymphoma or Burkitt lymphoma may present with a spontaneous tumor lysis syndrome, kidney failure, hyperuricemia, or may present with hypercalcemia like HTLV1 lymphoma, or may present with respiratory symptoms, acute respiratory symptoms, superior vena cava syndrome, obstructive airway symptoms, or may present with hyperviscosity syndrome, confusion, blurring of vision, like what we see in Waldenstrom disease, or may present with spinal cord compression if it involves the spines or the spinal cord, or lymphomatous meningitis if the lymphoma involves the brain or meninges, or may present with hematologic presentation such as severe autoimmune hemolytic anemia or ITP, thrombocytopenia. Laboratory values. CBC shows pancytopenia. That's due to bone marrow involvement and hypersplenism. Peripheral blood smear, lymphocytosis, circulating malignant cells, leukemic phase of lymphoma. Chemistry, high LDH in high-grade lymphoma. Chemistry, remarkable for hyperuricemia in case of tumor lysis syndrome. Hypercalcemia, HTLV associated lymphoma. Serum protein electrophoresis and immunofixation measures MS Pike. Diagnosis. Tissue diagnosis requires excisional or incisional biopsy, not only for diagnosis but also for classification, which will guide the treatment. Core needle biopsy, acceptable in certain cases. Please do not do fine needle aspiration, FNA, to diagnose lymphoma. The tissue should be a fresh tissue, not fixed in formalin. Histology will differentiate between different types of lymphoma, follicular versus diffuse cell lymphoma, and of course will tell us about the grade. Flow cytometry, biomarkers for B cell versus T cells. T cells, usually they are CD3, CD4, CD5, the lower number. CD stands for cluster of differentiation, which is a protocol to differentiate types of lymphoma. B cells, higher number typically, CD19, CD20, CD22, 25, 79, and so on. These are B cells biomarkers. That is obtained by flow cytometry. Molecular studies, B cell receptors, T cell receptors, rearrangement. Cytogenetics, karyotypes, and of course FISH. Initial evaluation for lymphoma, CBC and peripheral blood smear, which may show circulating lymphoma cells. Anemia, thrombocytopenia, or leukocytosis or leukopenia, all this could be obtained by CBC. Chemistry, renal and hepatic function, LDH and uric acid, serum protein electrophoresis, and immunoglobulins, beta-2 microglobulin tumor marker. Don't forget serology, HIV, hepatitis B and hepatitis C serology. Bone marrow aspiration and biopsy in some cases. LP, especially if there is neurological symptoms, abnormal brain, CT or MRI, more than one extranodal site, or extranodal involvement of certain organs, kidney, adrenal gland, testes, breast. LP is part of the workup for those type of lymphoma. CT scan with contrast. PET scan, very crucial for initial evaluation and during the treatment. Echocardiogram, if you are going to use cardiotoxic drugs such as anthracycline. Staging, probably you have heard of an Arbor classification. This is very similar, but is very specific for non-Hodgkin lymphoma. Lugano classification. Stage 1, one group of lymph nodes. Stage 2, two groups of lymph nodes in the same side of diaphragm. Stage 3, both sides of diaphragm. Stage 4, diffuse or disseminated involvement of one or more extralymphatic organs, bone marrow, liver, lung, with or without lymph nodes. Bulky disease. Lymph node mass of 6 cm for follicular lymphoma, diffuse large B-cell lymphoma, lymph node mass 6 to 10 cm to make it a bulky disease, and we put an X next to the stage. 1X, 2X, 3X, 4x. We'll start with B-cell lymphoma. B-cell lymphoma characterized by CD19, 20, 25, 22, 79. These are the biomarkers in the surface of the cell. This is how we differentiate B-cell from T-cell lymphoma by the CD or cluster of differentiation, which is a protocol for lymphoma. First, intermediate and high-grade non-Hodgkin diffuse large B-cell lymphoma. Diffuse large B-cell lymphoma is the most common subtype of non-Hodgkin lymphoma, 25%. Expresses CD19, CD20, CD22, CD79A. Cell of origin, two types. Germinal center B cell, relatively good prognosis. Non-germinal center B cell lymphoma, higher relapse rates, less favorable prognosis. Diffuse large B cell lymphoma should be checked for certain biomarkers, c-MYC, BCL2, BCL6. The treatment is guided by certain prognostic risk factors forming the International Prognostic Index, age of more than 60, LDH more than normal, performance status ECOG of more than 2, ECOG stands for Eastern Cooperative Oncology Group, stage of the disease, stage 3 or 4, extranodal involvement of more than 1. Then we give the patient a score 0 to 1 prognostic factor. If we treat with chemoimmunotherapy, the chance of complete remission 87%, and you can see for high risk 4 or 5 prognostic factor on the left side, the CR rate is down to 44%. Treatment of limited disease, stage 1 or 2, one group of lymph nodes or two groups of lymph nodes in the same side of the diaphragm. Non-bulky disease, remember bulky means lymph node mass more than 6 or 6 to 10 centimeter, less than that, non-bulky, and no adverse features. Elevated LDH, remember, is a bad feature. Performance status 2 to 4, bad feature. If none present, we treat with chemoimmunotherapy or CHOP for 4 cycles. If elevated LDH or poor performance status, we treat either for 6 cycles or 3 cycles followed by involved field radiation therapy or involved site in radiation therapy. On the other hand, for bulky disease, we treat with a total of 6 cycles followed by involved site radiation therapy. This is the R-CHOP. R stands for rituximab, C cyclophosphamide, H for hydrodonorubicin, O oncovine, P prednisone. Treatment of advanced stage 3 or 4, advanced germinal center B-cell lymphoma. We treat with 6 cycles of R-CHOP. Elderly, we reduce the dose. Non-germinal cell lymphoma, the best regimen not identified yet, so we prefer clinical trial. If you have to treat R-CHOP, with or without one of the novel agents. Advanced double-hit diffuse large B-cell lymphoma has poor prognosis with the R-CHOP, so we treat with multi-agent chemotherapy regimens. Patient survival without therapy only months. However, when we treat with chemoimmunotherapy, may cure those patients. Survival rate 70% at 3 years, 60% 5 years, and 45% in 10 years. Treatment of relapsed or refractory diffuse large B-cell lymphoma. You may need to repeat biopsy to confirm the relapse, rule out other causes, evaluate for new mutations. The treatment either salvage chemotherapy, in this case is rituximab with chemotherapy called ICE, and then we follow that with autologous stem cell transplant as a consolidation. Or we may treat nowadays with chimeric antigen receptor, CAR T. We'll talk about it a little bit in the next slide. What is CAR T? CAR T stands for chimeric antigen receptor T cells. It is genetically modified, engineered, if you will, artificial receptors to direct the patient's T cell against the patient's own lymphoma. So it is made specifically for that patient. CD19 directed CAR T immunotherapies are available nowadays for use. Another type of B-cell lymphoma is primary mediastinal large B-cell lymphoma. Primary mediastinal large B-cell lymphoma is the unique type of diffuse large B-cell lymphoma, unique in its presentation and treatment. So it differs from the classic diffuse large B-cell lymphoma. It occurs during the third and fourth decade of life. It originates from thymic medullary B cells. It is characterized by superior vena cava syndrome and obstructive airway symptoms. Treatment, if it is limited within one radiation field, we treat with either R-CHOP followed by involved field radiation or more intense chemotherapy, de-escalated combination chemotherapy, EBOC, which stands for etoposide, oncovine, cyclophosphamide, and doxorubicin with rituximab, combination chemotherapy. For refractory or relapsed disease, treating clinical trial, or the same way we treat the diffuse large B-cell lymphoma, either autologous stem cell transplant or CAR T. Another type of lymphoma is Burkitt lymphoma. Burkitt lymphoma originates from germinal center B cells. It is characterized by c-Myc gene expression, starry sky pattern under the microscope. Also, it is characterized by spontaneous tumor lysis syndrome, and it has a very short tumor doubling time. It could be days or maybe weeks. This disease, if not diagnosed and treated immediately, it takes life. There are three forms of Burkitt lymphoma. Endemic type, which is an African type, characterized by jaw and facial bone tumor. I still remember a boy with a very large jaw mass in one of the textbooks. I think it was Muir's of pathology. I don't know if the picture is still present or not in the new editions. Second type is a sporadic, non-endemic Burkitt lymphoma. It is mainly in Western countries. It involves the abdomen mainly. And the third type is immunodeficiency associated Burkitt lymphoma associated with AIDS, or HIV. There is what is called Burkitt-like like lymphoma, characterized by c-MYC and one of the BCL2 or BCL6 or both rearrangements. It is called double hit lymphoma. Also, it has very aggressive course and needs immediate attention and treatment. Treatment of Burkitt lymphoma needs frequent multi-agent chemotherapy with CNM prophylaxis. Regimens are very complicated, intense short duration regimen listed here. CHOP not adequate for Burkitt lymphoma. Primary CNS lymphoma. Primary CNS lymphoma, from the name, it involves brain, leptomeninges, eyes, spinal cord, without systemic disease. Risk factor is immunodeficiency, which could be due to HIV, AIDS, ataxia, telangiectasia, Westcott elderly syndrome, common variable immunodeficiency, X-linked lymphoproliferative disease, MRI of the brain is very characteristic for periventricular lesions. All the time should examine testicles by doing exam and ultrasound because testicular lymphoma has high tendency of going to the brain. When we treat primary CNS lymphoma, we take into account age of the patient and kidney function. Patient 70 or younger with good kidney function, GFR more than 30, we do treat with high-dose methotrexate-based chemotherapy, with or without radiation to the brain. On the other hand, elderly patients 70 and older, poor kidney function, GFR less than 30, we treat with mild chemotherapy, cytarabine, and temozolomide oral chemotherapy. Now we move to low-grade non-lymphoma, follicular lymphoma. Follicular lymphoma, it is the second most common type of lymphoma derived from germinal center B cells. Pathologists under the microscope look for centrocytes, which are small cleaved follicular center cells, and centroblasts, which are large non-cleaved follicular cell lymphoma, and they have to count them because centroblast less than 5%, that means it is a slow growing grade 1 follicular lymphoma. 6 to 15 grade 2, more than 15% grade 3 follicular lymphoma, which behaves and should be treated similar to diffuse large B-cell lymphoma. That's why the grading of follicular lymphoma is very important. Follicular lymphoma is characterized by translocation between chromosome 14 and 18, which lead to production of BCL2. BCL2 leads to blocking of apoptosis or programmed cell death, so the cells don't die, and that is a hallmark of malignancy, of course. This is the immune phenotype of the follicular lymphoma. Management of follicular lymphoma is actually a spectrum with two extremes: watchful observation, wait and see, all the way to stem cell transplant or CAR-T, and in between could be a single agent immune therapy rituximab or chemotherapy, two drugs, bendamustine rituximab, CBB3 drugs, or combination chemoimmunotherapy like R-CHOP. And on top of that, patient with coexisting hepatitis C virus could be cured by treating Hep C. Indication for treatment. Of course, we don't treat all follicular lymphoma patients. So the indication for treatment: local symptoms, compromise of normal organ function. B symptoms: fever, weight loss, sweats. Symptomatic extranodal disease, pleural effusion, for example. Cytopenia, which may indicate bone marrow infiltration, or autoimmune phenomenon, hemolytic anemia, thrombocytopenia, or hypersplenism. Increase in disease tempo. The speed of disease progression is increasing. That means we may have to stop that. So to help decide who to treat, there is a scoring system called FLIPI, Follicular Lymphoma International Prognostic Index, taking into account age of the patient, stage of disease, hemoglobin, involved nodal areas, more than 4, LDH, upper normal, and then based on that, we come up with the low risk, intermediate risk, high risk. So that helps us to decide who to treat, the FLIPI, and now is revised from FLIPI 1 to FLIPI 2. Relapsed or refractory follicular lymphoma. At time of relapse, we should perform another biopsy, first to confirm the relapse, second to rule out transformation into a diffuse large B-cell lymphoma. Early relapse, treated with autologous stem cell transplant, if candidate, of course. If not, chemoimmunotherapy, radiation immunotherapy, or a new drug which is a target for an enzyme EZH2. Late relapse, treated with chemoimmunotherapy. Novel agents listed here. Mantle cell lymphoma. Mantle cell lymphoma, by the way, is considered a low-grade lymphoma, but it is difficult to treat. It is characterized by translocation between chromosome 11 and 14, which lead to cyclin D1 gene. This is the immunophenotype. It is also characterized by GI involvement, forming lymphomatous polyposis in the colon. So we recommend to do EGD and colonoscopy for GI symptoms or signs, or even for patients with stage 1 and 2. Why? Because they could have colon involvement which change the stage. So if the patient is diagnosed with stage 3 or 4, EGD colonoscopy is not necessary in the absence of symptoms, but stage 1 and 2, it is recommended to rule out advanced stage because this disease characterized by involvement of the GI tract. Treatment of mantle cell lymphoma: young, healthy, symptomatic patients with advanced disease, either clinical trial or chemoimmunotherapy, followed by stem cell transplant, followed by maintenance rituximab immune therapy for 3 years. Very aggressive therapy for a low-grade lymphoma. Other options: combination chemotherapy. For stage 1 and 2, you can do chemoimmunotherapy for 3 cycles, followed by involved site radiation therapy. Refractory and relapsed mantle cell lymphoma, salvage chemotherapy alone, survival only months. So should be treated with salvage chemotherapy, followed by autologous stem cell transplant or even allogeneic transplant. New agents: protons tyrosine kinase inhibitors, BTK, ibrutinib. These are other options, or even CAR T. Another type of low-grade lymphoma, marginal zone lymphoma. These are the four types of marginal zone lymphoma: nodal marginal zone lymphoma, extranodal marginal zone lymphoma. The best example is mucosa-associated lymphoid tissue mold or moldoma, primary cutaneous marginal zone lymphoma, splenic marginal zone lymphoma. Marginal zone lymphoma arises from post-germinal center marginal zone B cells. This is the immune phenotype. Remember the CD, or the cluster of differentiation. Marginal zone lymphoma characterized by very unique chromosomal translocations. Uh, translocation 11-18 between chromosome 11 and 18 is one of the characteristics of some of the marginal zone lymphoma, especially of the gastric lymphoma. It is when it is found, it is less likely for the marginal zone lymphoma to benefit from H. pylori therapy. We'll talk about this later, but this translocation is very unique and has therapy implication. Marginal zone lymphoma has some association with other diseases, especially infectious diseases. Marginal zone lymphoma could be associated with autoimmune disorders. We'll talk about this in the coming slides. Gastric extranodal marginal zone lymphoma or moldoma is associated with H. pylori, or actual H. pylori is the cause of some of the gastric marginal zone lymphoma. Because of the strong association, if the biopsy is negative for H. pylori, biopsy and the lymphoma is negative for the H. pylori, we advise to do stool antigen for H. pylori or H. pylori urea breath test. Ocular adnexal extranodal marginal zone lymphoma is associated with chlamydia psittaci. Campylobacter jejuni is associated with immunoproliferative small intestinal disease, IPSID, or Mediterranean lymphoma, or alpha heavy chain disease. Prolia associated with solitary cutaneous extranodal marginal zone lymphoma. Achromobacter also associated with pulmonary or lung extranodal marginal zone lymphoma. The only one of those is the gastric lymphoma, that the treatment of H. pylori could lead to a treatment of the lymphoma. So eradication of the H. pylori is considered treatment for most of the gastric lymphoma, especially in the early stages. Let us discuss treatment of some of those lymphomas. The nodal marginal zone lymphoma is treated very similar to the other low-grade lymphoma or follicular lymphoma. Basically with immune therapy with or without chemotherapy or observation. So very similar to the follicular low-grade lymphoma. In the case of relapse, we treat with immune therapy, chemotherapy, or targeted therapy, ibrutinib. Treatment of gastric marginal zone lymphoma is stage 1 and 2, moldoma. This is the kind of cancer treated with antibiotics. For the H. pylori negative marginal zone lymphoma of the stomach, if the tumor is localized and could be encompassed in a single radiation field, then we could treat with involved site radiation therapy and then repeat EGD every year for 2 years. But if the tumor is large or in multiple sites in the stomach that cannot be encompassed in a single radiation field, then our option is observation until the patient becomes symptomatic. That is, if the disease was is found in EGD and the patient is asymptomatic or minimally symptomatic. But if the patient becomes symptomatic, we treat with systemic therapy, which is immune therapy rituximab. Here is the interesting part. If the marginal zone lymphoma is associated or quote unquote caused by the H. pylori, so H. pylori positive gastric marginal zone lymphoma, the treatment is H. pylori eradication. And then we repeat EGD every 3 months until complete remission, then every 6 months for 2 years, then as needed. If the treatment with antibiotics, the H. pylori regimen, fails, then we treat with involved site radiation therapy and do EGD every year for 2 years after radiation. For progressive disease, then we go to the systemic therapy, which could be immune therapy rituximab with or without chemotherapy. In case of perforation, bleeding, or obstruction, the treatment is surgical resection. When we treat to eradicate the H. pylori, we should confirm the H. pylori eradication. It should be confirmed with the available test. Up to 20% of patients with gastric marginal zone lymphoma treated with H. pylori eradication may require a second regimen. And we should give up to 3 regimens before pursuing alternative therapy. Then we don't jump to chemotherapy immediately. So we don't call it refractory until we try 3 different regimens for H. pylori. In case of advanced gastric marginal zone lymphoma, stage 3 and 4, still we treat with H. pylori eradication therapy, and then observe the patient. If the patient becomes symptomatic, then we use Rituxan with or without chemotherapy. So even with advanced disease, we do not jump to the chemotherapy and rituximab. For H. pylori negative, we treat when the patient is symptomatic. Non-gastric marginal zone lymphoma, like skin or thyroid, if it is limited stage 1 or 2, not causing symptoms or trouble, may observe those patients, especially stage 1 disease. Otherwise, radiation therapy is a treatment of choice. If you try to avoid radiation, such as radiation of the lung that may lead to pneumonitis, then you may do surgery. Other option is rituximab, systemic therapy. For the advanced stage 3 or 4, we treat similar to nodal marginal zone lymphoma. By the way, if the marginal zone lymphoma has a component of diffuse large B-cell lymphoma, we should treat as diffuse large B-cell lymphoma with R-CHOP. Splenic marginal zone lymphoma. Splenic marginal zone lymphoma, characterized by splenomegaly, plus a very characteristic peripheral blood smear findings, which will show villous lymphocytosis. Villous lymphocytosis, very characteristic to pathologists. 20% of marginal zone lymphoma may manifest with an autoimmune disease. This is immunophenotype, or the CD, or cluster of differentiation for the splenic marginal zone lymphoma. A splenic marginal zone lymphoma treatment. Asymptomatic patients, those without splenomegaly and without cytopenia, we observe them. However, we may treat autoimmune complications. We will review those complications later on. Splenic marginal zone lymphoma with hepatitis C infection could be treated with antiviral therapy. However, symptomatic patients, splenomegaly and cytopenia, those we may treat with rituximab or splenectomy. For progressive disease, we use systemic therapy such as oral treatment ibrutinib. This is a non-chemotherapy drug. Hepatitis C negative or patients not candidate for antiviral therapy or those who received antiviral therapy for hepatitis C but no response, those we treat with rituximab or splenectomy if they are symptomatic. For progressive disease, we use again systemic therapy ibrutinib, oral non-chemotherapy agent. Now, complications of splenic marginal zone lymphoma. Autoimmune hemolytic anemia, usually warm IgG antibody autoimmune hemolytic anemia. Immune thrombocytopenia or ITP. Cold agglutinin disease, it's an IgM. Antiphospholipid antibodies. Acquired von Willebrand disease. Acquired C1 esterase inhibitor deficiency. Let us review those complications one by one because as an internist or general practitioner may see this patient in the hospital or in your clinic and you have to deal with them and treat them. First, you need to diagnose them. How we diagnose autoimmune hemolytic anemia? Basically, we test for antibodies directed against RBCs and that leads to hemolysis. The first test is direct antiglobulin test or DAT, also called direct Coombs. The antibodies are actually on the surface of the RBCs, so they are in the RBCs, they are not in the plasma. So the patient's RBCs, which are coated with antibodies, we have them in a test tube and we add to those RBCs an anti-IgG. So it is an antibody against the antibodies which are in the surface of the red cells. And that will lead to agglutination and that eventually to hemolysis. So agglutination does not occur in vivo. It has to be a test in vitro. The other test is indirect antiglobulin test or IAT or indirect Coombs. Here the situation is different. The antibodies actually are present in the plasma. For direct Coombs, the antibodies present in the RBCs. So here the antibodies are present in the plasma. So we use a patient plasma which has antibodies and here we add test RBCs that are already in the blood bank. And we add to that the plasma, the patient plasma and the test RBCs, we add to them an anti-human antibodies, and that will lead to agglutination and eventually hemolysis. So the primary warm autoimmune hemolytic anemia is the one that's associated with the splenic marginal zone lymphoma. But also there is a secondary warm autoimmune hemolytic anemia, which is related to other autoimmune diseases and lymphoproliferative disorders, immunodeficiency, medications such as antibiotics, infectious diseases, mycoplasma pneumonia, These conditions may lead to warm autoimmune hemolytic anemia and IgG warm antibody. The warm antibodies are IgG directed against multiple RBC antigens. And as I said, we test those with direct COMS, so the direct COMS should be positive. So for warm immune hemolytic anemia, the test of choice is direct COMS test, and it should be positive to make the diagnosis of warm autoimmune hemolytic anemia. Haptoglobin is low, and high direct bilirubin and high LDH are indicators for hemolysis. So you get low haptoglobin, high indirect bilirubin, high LDH, direct COMS test or DAT. This is a diagnostic for warm autoimmune hemolytic anemia. The RBCs are cleared extravascularly in the reticuloendothelial macrophages, like in the spleen. Intravascular hemolysis also could occur, but only in severe cases. But primarily, the hemolysis is extravascular, like in the spleen. How we treat: glucocorticoid, steroids, with or without rituximab, anti-CD20. If you use prednisone, 1 to 2 milligram per kilogram for 2 to 3 weeks, followed by slow tapering of the steroid, probably over 6 weeks, or could be longer. Severe intravascular hemolysis, if that's the case, we may treat with cytotoxic drug cyclophosphamide. Alternatives: CellCept, sirolimus, or even spironectomy for severe cases. We supplement those patients with folic acid because of the high turnover during hemolysis. Another form of splenic marginal zone lymphoma complication is immune thrombocytopenia, which is equivalent to ITP. Because ITP is a diagnosis of exclusion, we should rule out other causes such as drug-induced thrombocytopenia, which is typically characterized by platelets in the range of 50 to hundreds, so not very low platelet count. Those patients with thrombocytopenia also should be screened for infectious causes: HIV, hepatitis C viral infection, and H. pylori. For immune thrombocytopenia or ITP, the treatment depends on the degree of the thrombocytopenia. For platelet count of more than 30,000, usually observe those patients. For severe thrombocytopenia with very low platelets of less than 30, like 5,000, 2,000, 3,000, 10,000, or severe bleeding, we could transfuse platelets for bleeding or hemorrhage. Otherwise, we don't give platelets for ITP because it will be consumed very rapidly. The treatment of choice is IVIG or corticosteroids or thrombopoietin agonist like romiplastim M-plate, which is an injection. A general approach for platelets of more than 30,000, again, only observation. For platelet count of less than 30,000 or bleeding, our options are listed here: steroid, spironectomy, rituximab. Recently, there are new drugs with the idea to overcome the destruction of platelets peripherally, overcome that by producing more platelets in the bone marrow by using thrombopoietin receptor agonist listed here, romiplastim, M-plate injections, Promacta tablets, and so on. Cold agglutinin disease, another form of splenic marginal zone lymphoma, CAD. Cold agglutinins, DAT or direct COMS is positive with but it is instead of IgG, it is with anti-C3, negative with IgG. And the hemolysis is extravascular, again, extravascular in the macrophage, in the spleen. No hemoglobinuria. And one of the characteristic clinical finding is livedo reticularis. Treatment, prednisone or steroid, typically they don't work well for this disease. So we do treat with anti-CD20 immune therapy rituximab, with or without chemotherapy bendamustine. If the patient has monoclonality, M-spike, or if rituximab is not effective, then we use bortezomib, Velcade. Plasmapheresis plays a crucial role in this disease, especially if the titer is very high and the patient is very symptomatic. Remember, protect those patients from cold, any cold, AC, cold weather, cold, anything cold, because the hemolysis is severe in cold condition, cold weather. So keep them warm. Paroxysmal cold hemoglobinuria, and then cryoglobulin, which doesn't cause hemolysis, it causes vasculitis. But remember, cold agglutinin disease, keep the patient warm. Direct Coombs test positive with anti-C3, negative IgG. Livedo reticularis is the clinical finding. Do not use a steroid for this patient. Treat them with immune therapy, rituximab. Plasmapheresis for severe hemolysis. Another form of complication related to splenic marginal zone lymphoma, antiphospholipid syndrome. When to suspect antiphospholipid syndrome? Unexplained venous or arterial thrombosis. Adverse pregnancy outcomes, livedo reticularis, valvular heart disease, neurologically cognitive deficit, lab, mild thrombocytopenia is typically mild, 50, 60, 70,000 platelets, less than 100. Prolonged PTT is also lab finding. History of false positive syphilis test. Those are the things make you suspect antiphospholipid syndrome. Diagnosis, the clinical picture, of course, and antiphospholipid profile, antiphospholipid antibody test, which is anticardiolipin antibodies, anti-beta-2 glycoprotein antibodies, lupus anticoagulant. Treatment of antiphospholipid syndrome. This is a very busy slide, but I'll just summarize it in few words. Antiphospholipid without thrombosis, no indication for anticoagulation. So don't treat the lab just because of antibody positive, anticardiolipin positive. As long as there is no thrombosis, there is no indication for antithrombotic medication. Patients with acute venous thromboembolism, we should treat with heparin and then leave them on warfarin forever. But don't use the new drugs, DOAC. And also add low-dose aspirin in case of arterial events. So for venous events, heparin followed by warfarin for life. Pregnancy with antiphospholipid, we treat with therapeutic dose, low molecular weight, then switch to warfarin after delivery. Use low-dose aspirin to reduce risk of preeclampsia. Pregnant with incidental persistent antiphospholipid antibody without the syndrome or thrombosis, only aspirin is. Acquired von Willebrand syndrome as a complication of splenic marginal zone lymphoma. These are the major causes of acquired von Willebrand disease. We say acquired because von Willebrand disease, by definition, it is congenital. But these are the causes of the acquired form of von Willebrand disease. Try to differentiate the acquired from congenital. The treatment is von Willebrand factor concentrate, DDAVP, IVIG, typically for the acquired, not for the congenital. Treat the underlying condition. You may need to treat the lymphoma to treat the von Willebrand syndrome. Acquired C1 inhibitor deficiency, very rare, so I'm not going to spend time on it. But if you like to go back to the slide, you could review. Another low-grade lymphoma is lymphoplasmacytic lymphoma. From the name, it is a lymphoproliferative disorder characterized by lymphocytes disorder and plasma cell disorder. Another name for it is Waldenstrom macroglobulinemia because of IgM production. So either name you choose is fine. It is the same disease, lymphoplasmacytic lymphoma or Waldenstrom macroglobulinemia. Waldenstrom macroglobulinemia or lymphoplasmacytic lymphoma is a lymphoma of the bone marrow. Less commonly could involve the spleen and or lymph nodes. It is characterized by IgM monoclonal gammopathy, which lead to hyperviscosity syndrome, which presents as blurring of vision, headache, ataxia, or dementia, or stroke, or even coma, or nasal bleeding. Very characteristic picture of retinal veins like sausage, paresthesias and weakness, neurological presentation due to infiltration of CNS by plasmacytoid lymphocytes. It is called Bing-Neal syndrome. Waldenstrom macroglobulinemia is associated with a very unique gene mutations, MYD88 or CXCR4. It is done if the diagnosis is questionable. To confirm or rule out the disease, you could use these gene mutations. The bone marrow is typically involved by more than 10% with the lymphoma cells, either lymphocytic or plasmacytic cells, and here are the phenotype of those malignant cells listed here. Treatment of lymphoplasmacytic lymphoma or Waldenstrom macroglobulinemia depends on symptoms. Patients with constitutional symptoms, fatigue, fever, or patients with cytopenia due to bone marrow infiltration or other tissue infiltration like CNS. Those patients, we treat them with immune therapy and chemotherapy, bendamustine, rituximab. Patients with hyperviscosity syndrome, the treatment of choice is plasmapheresis plus immune therapy or even chemotherapy. But plasmapheresis is the treatment of choice for hyperviscosity syndrome due to Waldenstrom macroglobulinemia. Also, the treatment could be directed to associated conditions like amyloidosis, cryoglobulinemia, hemolytic anemia, or cold agglutinin. Remember, this is an IgM disease. Treatment of choice is Velcade, which is a non-chemotherapy drug with rituximab, or even chemotherapy with rituximab. Paraneoplastic neuropathy associated with the Waldenstrom macroglobulinemia treated with immune therapy, rituximab, or chemotherapy. Elderly not eligible for aggressive cytotoxic drugs treated with non-chemotherapy drug ibrutinib oral therapy, and rituximab, or even without rituximab, just single agent. General rules: low tumor burden, mild symptoms, rituximab with or without chemotherapy. High tumor burden, moderate to severe symptoms, those we treat them with immune therapy and chemotherapy, rituximab and bendamustine or Cytoxan, dexamethasone and rituximab, Velcade, dexamethasone and rituximab, non-chemotherapy, ibrutinib, non-chemotherapy drug, oral therapy. For patients with very high level of monoclonal IgM, more than 4 grams per deciliter, very high, those patients, we treat them with chemotherapy or plasmapheresis to remove the IgM uh, from the plasma before rituximab, because it could aggravate the disease if we give rituximab upfront. So plasmapheresis or chemotherapy first, then rituximab. Relapse disease, we treat could be same regimen or different type of chemotherapy. Another type of lymphoma is HIV or AIDS-related lymphoma. AIDS-related lymphoma. These are the lymphomas associated with AIDS, diffuse large B-cell lymphoma, high-grade primary CNS lymphoma, Burkitt's lymphoma, plasmaplastic lymphoma. Presentation: B symptoms, typical advanced stage disease, extranodal presentation, GI, pulmonary, bone marrow, or treatment of AIDS-related lymphoma. The best outcome and higher CR rate if we use antiretroviral therapy, ART, plus chemotherapy at the same time. However, we should avoid zidovudine, cobicistat, and ritonavir due to drug-drug interaction. Chemotherapy regimen based on type of lymphoma. Remember to hold rituximab for CD4 count less than 50. Patients with very low CD4 count, we avoid giving them rituximab anti-CD20. Remember to give them those patients prophylactic antibiotics for PCP, herpes, candida prophylaxis, and enteric organism prophylaxis. This is the last slide for the B-cell lymphomas. Post-transplant lymphoproliferative disorder, PTLD. This is a complication of solid organ or hematopoietic stem cell transplant. Risk factor for this disorder is prolonged immunosuppression, T-cell depleted grafts, umbilical cord, and haploidentical transplants. EBV or Epstein-Barr virus seropositivity prior to transplant. Treatment for EBV positive PTLD: reduce or may discontinue the immune suppression, may lead to up to 50% regression of this disease. Antiviral, ganciclovir, rituximab, if increasing EBV viral load. Finally, we are done with the B-cell lymphomas. Now we are going to switch gears and go to the T-cell lymphomas. Remember, T-cell lymphoma has different biomarkers. Remember, the B-cell lymphomas has higher CDs biomarkers, CD19, 20, 22, 25, 79, and so on. For the T cell, the biomarkers has lower numbers, CD2, CD3, CD4, CD5, CD7. In addition, there are some markers specific to the T cell lymphomas, TCR, T cell receptor rearrangement. Some lymphomas may have the ALK rearrangement, and some may have the CD30, which has therapeutic implications. We'll start with peripheral T cell lymphoma, PTCL. There are several types listed here. The anaplastic large cell lymphoma, angioimmunoblastic T cell lymphoma, AITL, extranodal natural killer T cell lymphoma, nasal type, adult T cell lymphoma leukemia. So these are the types of the lymphoma, the T cell lymphoma. Peripheral T cell lymphoma, less than 15% of non-Hodgkin lymphoma. This is the immunophenotype of the peripheral T cell lymphoma. The lower CDs, CD2, CD3, CD5, 7, and B cells has to be negative. Rarely we see some CD20 positive, but that's not the common scenario. The clonal TCR rearrangement, very characteristic and diagnostic for T cell lymphoma, the clonality of T cell receptor rearrangement. There are some cytogenetics associated with the peripheral T cell lymphoma. Treatment of peripheral T cell lymphoma, induction. Remember the CD30. We said we use it for therapies. So lymphomas with more than 10% positivity for CD30, we treat them with anti-CD30, which is brentuximab, in addition to chemotherapy. If there is less than 10% CD30, we consider that negative, and we treat with chemotherapy without anti-CD30 brentuximab. Consolidation, either radiation therapy or a stem cell transplant. Anaplastic large cell lymphoma, another type of T cell lymphoma. Primary systemic anaplastic large cell lymphoma. There are two types, either ALK positive or ALK negative, ALK negative, ALK positive. The ALK positive, some people call it ALKoma, just to make it easy. Breast implant associated anaplastic large cell lymphoma. Primary cutaneous anaplastic large cell lymphoma. Primary systemic anaplastic large cell lymphoma, if it is CD30 positive, we treat with anti-CD30, which is brentuximab, in addition to chemotherapy. Of course, if CD30 negative, we use chemotherapy alone. For stage 1 and 2, not able to tolerate chemotherapy, we give 3 to 4 cycles of chemotherapy, consolidates with radiation. These are the options for relapse disease, including single agent brentuximab, stem cell transplant, and different types of chemotherapy. Adult T cell leukemia lymphoma, ATL. Adult T cell leukemia lymphoma is associated with the human T lymphotropic virus type 1, HTLV1, and there are 4 forms of this disease. It could be an acute adult T cell leukemia lymphoma, it could be a lymphoma type, or chronic disease, or a smoldering disease. Acute lymphoma type or unfavorable chronic type ATL, we treat them with aggressive, very complicated chemotherapy regimens. The simple regimens are CHOP or CHOP-like regimen or hyper-CVAD. Another form of T-cell lymphoma is cutaneous T-cell lymphoma. There are two forms: mycosis fungoides, which is primarily skin form of the lymphoma, and Sézary syndrome, which is characterized by circulating lymphoma cells, which are the Sézary cells. For the early stage mycosis fungoides, we treat with skin-directed therapies, corticosteroids, or topical nitrogen mustard, or even ultraviolet light. For highly symptomatic patients with generalized thickened plaques, in addition to the uh, skin-directed therapy, we may use uh, total skin electron beam therapy and other forms of skin-directed therapies with systemic biologic therapy or Sézary syndrome is an aggressive leukemic variant of cutaneous T-cell lymphoma, characterized by circulating malignant Sézary cells in peripheral blood, erythroderma, and lymphadenopathy. Treatment is mainly systemic, with or without skin-directed therapy. And for solid organ stage 4 disease, we may use chemotherapy or immunotherapy like romidepsin. I believe this is the last slide. Take home message number one: lymphoma is a heterogeneous group of malignancies. They do not have common clinical presentation other than lymphadenopathy and maybe the B symptoms. Otherwise, presentation varies according to histologic subtypes and sites of disease. For accurate diagnosis, you need adequate tissue for proper diagnosis and classification. That means no FNA, because you are not going to get adequate tissue for that purpose. The tissue should be fresh tissue, not fixed in formalin. For proper and accurate diagnosis, you need a lab equipped with flow cytometry, molecular, and fish studies. Take home message number two: keep in mind, not all lymphomas require immediate treatment. Some they may not need treatment at all. However, some could be life-threatening if not diagnosed and treated urgently and aggressively, such as Burkitt lymphoma. Immunotherapy, anti-CD20, rituximab, is used almost in all B-cell lymphomas regimen. So make sure to test your patient for hepatitis B serology, because hepatitis B carrier, if received rituximab, may die from fulminant liver failure. Be aware of tumor lysis syndrome, which could be spontaneous in aggressive, fast-growing lymphomas such as Burkitt lymphoma, or it could be therapy-induced, which is the commonest. So be aware of it, diagnose it, and treat it as an emergency and properly. And thank you much.